Thank you, Bhavna. Hello, everybody. Good afternoon. I'm very grateful to you all for inviting us. We're very excited to be here, very excited to be in a room full of people who care about innovation and for whom innovation is a draw word. It sort of draws you here at 4 o'clock in the afternoon when I'm sure you've got more pressing things to do either in the hospital or at home. What I'd like to do, we would like to do in the next sort of half an hour or so is talk a little bit about stimulating, incubating and scaling innovation. We have got some experience in this area. We've been operating, as Bhavna said, for about 12 years. We were established within government in 2002 and have been working, have been actually growing quite substantially from a team of about 5 people to about almost 40 people today, working predominantly in the UK, but quite a lot abroad now. I suppose what I probably should say, there's 3 words there on the right-hand side of that slide: learn, design, and transform, which I think encapsulate our approach. There are different schools of thought when it comes to innovation. If you go to the Harvard Business Review, they have a certain take on innovation. Design schools will have a certain take on innovation, and etc. I think because we originated in the Department for Education, learning is a very, very important component for us, and we believe, and there's quite a lot of evidence to suggest, that learning organizations are innovative organizations. Or certainly the ones that are innovative are almost in all cases learning organizations. That is to say, they make mistakes and they learn from them, they embrace learning and they embrace experimentation. So that's one thing. Design is something that we practice much more than we used to. For some people, innovation consultancy is about finding the best examples and shouting about them and writing about them and quantifying them. For us, it's doing that, but it's also rolling up your sleeves and trying things out and designing things with users, with practitioners. And finally, the transform word suggests that often it's not enough to come up with a brilliant idea or to design the new service, but you have to transform the system around it. You have to decommission some services to create room for the new service to take hold. And if you don't stop certain people from doing the thing that they always do, then there will be no room for the new innovation to take place. So in all of our projects, we operate simultaneously on designing the new thing, but also changing the system so that the conditions are there for innovation to take place. When we talk about innovation, we mean those 3 words. It has to be different to current practice. It has to be better. The outcomes have got to be better. The experience has got to be better. And in the budgetary environment that we've been in since 2008, it has got to be lower cost. Since the new Labour days are over, there is no more money for pilots and for testing new things. Those days are gone. We now have to prove that all innovations deliver efficiencies and deliver value for money to taxpayers. That is the reality I'm sure you are faced with here as well. And when we talk about innovation, we don't talk about gadgets. Sometimes there are products that we include within the projects, but often it's about processes, it's about innovation of the organization, who runs it, what is the business model behind it, what kinds of services, what kinds of system, etc. So we're very, very broad and holistic in our definition of innovation. In 2009, I think, we were commissioned by Nesta, which is the UK's Innovation Foundation, to conduct research into 100 examples of organizations around the world that managed to deliver those 3 words. So significantly better outcomes for lower cost. And nearly in all cases, it meant a different model, usually a very, very, very different model. I'll just run through some examples which you may know about because they're not new anymore. In Sweden, they set up patient hotels, I think it was end of the 80s or early 90s, when I think Lund Hospital in Sweden reached capacity and they were not able to afford building a new wing. Their approach was to commission SAS, which is one of the hotel chains in Sweden, to build a building adjacent to the hospital, which would run services for patients, but the patients were sort of in a non-medicalized environment. They did not wear hospital clothing. The nurses did not wear nurses' clothing. They wore sort of hotel uniforms, and the emphasis on well-being and on sort of creating a non-medicalized, non-institutionalized environment had massive results in terms of the time it took people to recover. The average cost of a bed in the hospital is roughly £260, and the average cost of a bed in the patient hotel is £70. So it's 1/4 of the price to keep patients in the patient hotel, and the recovery time was shorter. So it wasn't obviously for all types of patients. I think they started it with maternity care and with oncology patients, which didn't require certain treatments that were necessary to conduct in the hospital, but hospital was nearby. Patient hotels are now all over the world. They've certainly taken over Scandinavia. There's several in the UK. They might even be in South Africa, we don't know, but that's one example of radical innovation. This example from India, Narayana Hridayalaya, don't know if I'm pronouncing that right, probably not, provided very intensive cardiac care. Before it was set up in the early 2000s, 2.4 million people needed heart surgery every year, only 60,000 were treated, and 25% of heart attacks were occurring amongst people under 40, with 70% of doctors located in the cities. Narayana's mission was to treat as many patients as possible in whichever location they were. They set up remote coronary care units, which were out in various districts, and trained local doctors via telemedicine to support them in correct diagnosis, which was sent by the internet, which resulted in 99% of people being treated locally. Only 1% of patients that needed surgery were sent to Narayana. So quite a famous case study there. And then another final case study from Denmark, joint care, which focuses on group, both pre-operation but also recovery from hip and knee operation. So one of the things they do is they, again, emphasis well-being. Patients are encouraged to wear normal clothes, not hospital clothes. A lot of peer support, so a lot of these sessions are in group sessions, both before the operation and afterwards. There are economies of scale, which they achieve by having conveyor belt surgeries, so they have a whole cohort in a single day, and then they all recover together and offer each other group support. And again, the numbers behind that are very impressive. They reduced the length of stay from 6.5 to 3.9 days, I think that's not hours, and 50% increase in the number of patients able to get out of bed on the same day of the operation. Patient satisfaction, 95%. So those are 3 out of, as I say, a very large number of case studies that we looked at. And what we try to do is look at what are the commonalities, what are the things that we can learn about the process of coming up with innovations such as these. And this diagram is the one that we arrived at. The top 2 quadrants are new ways of looking at challenges. What are the new ways of creating new perspectives on the challenges? And that's about finding new sources of insight and creating a new lens on who your customers are, whether it's patients. So in the case of the patient hotel, they changed the unit of care from being a patient-focused to being a family-focused. And the patient hotel started to interact much more with families than it did with individual patients. And once you have spent a significant amount of time thinking about the challenges, only then you move on to develop new perspectives on the solutions by looking at who are the new suppliers that could disrupt the system, what are the new resources that you could either reuse or reduce in order to make the system more efficient. often people stop with new resources. They look at efficiencies first rather than as the last thing. And so that's one of the things that made this model unique. I'm going to mention one more model, and I know it can be a little bit theoretical, so I apologize. This diagram illustrates the flow of how people move, or organizations move, from problem on the left to solutions on the right. There's a sort of two diamonds and a funnel. And the left-hand diamond in brown is called the stimulate phase. The next one is called the incubate. And finally, there's the scale. And those are the three fundamental phases of innovation. Some organizations are very good at doing one of those. So they might be really good at stimulating innovation. They've got lots of people with bright ideas, but they're poor at taking those innovations to scale. Other organizations may be very good at incubating those ideas and sort of growing them and giving them the protective environments that are necessary. But then again, they fail to scale. And some are really good at scaling ideas, but they're not very original ideas, or there are not very many of them. So I think in all of our work, we have different emphases. There is no one right answer. And I think what we're trying to do with this Challenges program is certainly create all three of those. We're trying to stimulate the new ideas that are coming from staff, from patients. We're trying to provide a safe environment for those ideas not to hit a brick wall, not to be told, we tried that 10 years ago and it didn't work, not to be told, you're not allowed to make those changes. And then finally, once there is proof of concept, to be able to see how we can take those ideas to scale. And scale is quite possibly beyond the confines of this hospital alone. I'm going to hand over to Kate to talk about some of our other work.
Great. I'm going to tell you a bit about the work that we're doing in the UK, and it's obviously a very different setting from South Africa. Compared to here, I'm sure you all feel that all of this is very well resourced, that we can possibly have lessons that you can learn. But in the last 3-4 years in the UK, we have been having budget freezes. We've had to make £20 billion of efficiency savings across the NHS. So a lot of the work that Aviv and I have been doing in the Innovation Unit has been working with hospitals, with commissioners, with kind of local health areas, health and social care, to really understand how can they keep improving, delivering better outcomes, and while also trying to make efficiency savings. What are the different ways that they could be providing services? So I'm going to really quickly run through a couple of examples of work that we've been doing. I worked on a project called Mum's Power, and this was around maternity services. And we worked with two central London hospitals. And the challenge that they came to us with was introduction of a new tariff, which meant that the amount of money that they were going to get paid for looking after a kind of low-risk woman going through pregnancy was going to drop quite drastically. And I'm sure lots of you relate to some of the issues that we heard from midwives, from mothers. We heard from midwives, if only we had a shared record, then everything would be better. We'd be able to save so much money. We heard from mothers, if only I could see the same midwife every single time, then my care would be so much better. So neither of those two things were going to happen in the time frames that we were looking at. We weren't going to be able to provide more time with midwives. We weren't going to be able to provide more midwives, not with budget cuts. So we did a piece of deep user-led research and co-design with midwives, with women who'd recently had children, to understand what were their experiences of current services and what were the areas that we could really innovate around. So we heard from midwives that they were frustrated about the fact that they were just repeating the same information all day, that they felt like, why am I saying the same thing to every single person? I'm providing kind of cookie-cutter care. We heard from women that they were confused, they didn't have the information they wanted, that the reason they kept on coming back to the hospital was because no one had explained anything properly to them. So we tried a variety. All of this fed into a co-design process with midwives, with women who were either expecting babies or had just had babies, where they worked together to come up with new ideas of what services could look like. So you can see here a picture of a group appointment, which is when you have your antenatal care appointments all together throughout your pregnancy. So you have 8 group appointments. And we also tested some technology platforms, one which was designed to give clear information and one which was designed to better connect mothers to each other. So we worked with users and with staff to try and stimulate innovation, to get them to come up with great ideas which could transform their services. And one of the other things that we do is actually look at how to scale innovation. Across the UK there are thousands of innovators, there are thousands of pockets of great practice, there's people doing wonderful work everywhere, but actually the problem is it remains in pockets. It will remain with the team who invented it on a particular ward, or remain in the hospital that invented it. It doesn't scale up over the NHS. And considering we have one NHS, you'd think that would be easy, but it's not. So I worked on a project called People Powered Health, which was with Nesta, which is the UK's Innovation Foundation. And it was all around looking at what we call people-powered health solutions. And this was around self-management and supporting people to better support, to manage their long-term conditions. And so we worked with 6 different sites, and we tried to help them build the evidence they needed to scale, to build the networks that they needed to scale up what they were doing, both within their own site, but across other sites in the UK. So we worked with them to capture what they were doing, what were the really critical things that they were doing which was different, how could we capture that in a way that other people could adopt it easily. We worked with them to build stories and compelling evidence for why it was better for patients, why it was better for staff. And we worked with them to model the potential impact both in their localities, but also the potential impact across the NHS if you scaled up these approaches. And when you looked across the NHS, that was £4.4 billion out of a total budget of what is around now £110 million. So it was a substantial amount of money. And Aviv is now going to quickly tell you about our local hospitals work.
Okay, so in northwest London, which is a population size of about 2.5 million, McKinsey have been doing some work around the whole system, reconfiguring the whole system of primary and tertiary care to make it one that is more sustainable, both economically and also clinically safe. They came up with this model, which suggested that there should be 4 types of hospitals in this patch. A local hospital which provides 24/7 urgent care, outpatients, facilities, diagnostics, general practice and out of hours. A major hospital, which is a bit like this one. An elective hospital and a specialist hospital, which both provide very specialist care, whether it's elective surgeries, elective medicine, cancer, cardiothoracic, etc. So the brief that we got was to look at the first one, the local hospital. There are currently no local hospitals in the UK. There have been different plans for polyclinics, different sort of clinics that integrated both civic and medical care, health and social care, and the purpose of this local hospital was really to create a buffer between primary and community care and secondary and tertiary care in a way that was useful for patients and economically viable. So what kind of a place would be able to increase the well-being, the early intervention, and reduce acute admittance to tertiary care, at the same time increase the effectiveness of rehabilitation and sustained recovery. We approached this by, again, doing a lot of consultative work with patients and with clinicians. Some of these were big workshops in town halls. Some of them were deep dive sessions in which we spent 8 hours in elderly patients' homes, talking to them, really understanding their motivations, their drivers, what are their lives like. A lot of our work tends to have a period in which we spend really intensive one-on-one time with patients. Not the 1 hour interview, but literally 1 or 2 days to really understand everything, because there's a lot that you get after the 4 hour period that you don't get in short interviews. So the new model that we arrived at, and which is currently sort of being processed through a very, very heavy machinery, and will probably be built in 2018, involves quite a lot more empowering of carers, in fact. I think one of the things that we found out, which I think commissioners weren't aware of, is the extent to which carers, both formal and informal carers, needed a lot of training and a lot of support. A lot of it is moral support and recognition, but they needed a space, a physical space in the local hospital, and a role for clinicians to work with them. Besides that, there was sort of training facilities, etc. But I think the point I wanted to make was really about the process more than anything. I want to pause there. I think we've talked enough, and I want to give people in the room a chance to have a say about the question at hand, which is, what changes do you think would have the greatest impact on patients' experiences and outcomes in the hospital? So, if we could spend, say, 5 minutes in groups, just with any thoughts that we've brought to the room, or maybe thoughts that have been sparked by our presentation. But if we are going to spend, a significant budget on this challenge, where would you say the emphasis should be? Okay, so we'll just spend 5-6 minutes on that, and then we'll continue.
I just wanted to tell you a bit about what other healthcare organisations around the world are doing around innovation. And when you look at the best healthcare organisations, hospital systems, they almost all have some sort of innovation hub, centre, team, a team that can really support staff to think of new ideas and to implement those ideas. And I'm just going to share a couple of those with you here quickly. Kaiser Permanente, again, very different context. They have had loads of money to invest in a massive innovation centre. The principles are they have massive space for people to try out new ideas safely. It's a prototyping space, which is people can mock up what they might do in their ward or in their department, how they might relate to patients at home, and they can try out ideas there before they try them out with a patient. So it's safe, so you can take risks in a safe way. In Sheffield, on a kind of slightly smaller scale, a team were having problems there with the amount of frail elderly patients who are coming into the hospital, and who just ended up spending weeks, months in the hospital. So they went around redesigning the acute care system for frail elderly patients, and this meant bringing together all of these different professionals, from social services to the secretaries to the physiotherapists, the doctors, and they put aside a space in their hospital. They call it the big room, and that was where they held weekly meetings. And they said, we've set these priorities. This is what we want care to look like for this group of people, and we're going to keep on coming back to it until we've done it. And we're going to each of us commit to testing a new way of working, to making this change happen, and we're going to come back together and bully each other if we haven't. We're going to tell each other we have to make it happen. And then on the kind of user-led side, in the UK, Turning Point, which is a charity, have trained a range of patients to actually go out into communities and say, what do you want from your health services? To other patients, to members of the public, what does a great health service look like to you? And feed that into the way that the health services are designed and commissioned. So they really are centred around what patients need. And when we've worked building the innovation kind of capability, so basically enabling staff to be able to think of new ideas, and we've worked with hospitals and systems in London to try and do this. And I just wanted to kind of share 4 insights to close about actually what makes that happen and what a successful kind of program looks like, what a successful innovation program looks like. So firstly, it's not about the lone innovator. It's not about the lone person charging ahead with their good idea and taking all the glory. For this to really work, it's about teams, and it's often about mixed teams. So as you saw in the Sheffield example, it was about bringing together all the different players, allowing them to speak on equal terms, and not just one person running away with their brilliant idea. It's about bringing in outside perspectives. It's about bringing in outside perspectives. That might be looking outside your hospital walls for ideas from other sectors, but also whilst building the capability of the people inside the hospitals and really listening to the people who are here every day and know what needs to change. People need space, but that's not just physical space. Physical space is important, but they need time. They need a safe space to be able to take risks, and they need senior sponsorship. There's nothing more frustrating for the people that we work with than when they're told to think of a brilliant idea, they're told to go away and innovate, and actually when they do, they don't have the senior sponsorship to be able to unblock the barriers. So I think this is an amazing opportunity, because I've shown you examples from around the world, but this is an opportunity for this hospital to do some of that. And you have the buy-in of the board, you have the buy-in of the CEO to really make that change. So I'm going to pass over to Lindy now, who's going to tell you about what's next and how you can all get involved.